Good morning, I'm Dr. Discogenic, CEO and founder of Duke Spine Institute. It is January 14, 2025. Our patient travels from Florida with severe neck pain. She has two causes to her neck pain. She has some disc injuries called degenerative disc disease, and she has facet joint pain. We've just treated her facet joints a few minutes ago with the Duke plasma rhizotomy. It's a permanent elimination of facet pain, unlike an RFA, which is widely prescribed around the world, but it is ineffective 50% of the time, and patients' pain always comes back with RFA. With the Duke plasma rhizotomy we just performed, it's permanent pain relief, and it's outpatient. There is some soreness in the neck for a few days, maybe a week or two, and then the pain's gone completely and permanently, unlike the RFA. So we are now doing permanent pain relief for facet joints, but this surgery you're watching now is to fix two discs that are painful, number 5-6, C5-6, C6-7. We're going to start with C6-7. Now you're looking at the front of her neck. The first thing I'm doing, since I'm going on the left side of her neck, is I'm going to place a needle, spinal needle, in the disc. We're going to place the needle to the inside the disc and do a discogram. We're going to place a guide wire, make an incision, bring a dilator, and then a tubular retractor. It's 4 millimeters wide. This is outpatient surgery. It's virtually bloodless. And the success rate of this for eliminating neck pain from the disc is 99.6% on average. That's based on studying 5,000 of our patients. Okay, I'm going to start by placing the needle. If you have questions, feel free to ask me, but I have to get the needle into the disc. Okay, are you guys ready? Neck is somewhat supple. It probably could be a little bit suppler if you want to give her a little more relaxing. Meanwhile, just chat for another minute. Henry, why don't you show the audience the 30 most common causes of chronic neck pain, and then we'll talk about her problems when you're done.
Of course.
I'm Dr. Discogenic, CEO and founder of the Duke Spine Institute. We're going to talk about the 30 causes of chronic neck pain. Chronic neck pain is neck pain that lasts longer than 6 weeks. There are 30 causes to chronic neck pain. The most common cause is the disc. There are 6 discs in the neck. These discs can become injured. The first disc is C2-3, next is C3-4, C4-5, C5-6, C6-7, and C7-T1. The most common disc to be injured and cause neck pain is C5-6, followed by C6-7, followed by C4-5. The other discs rarely cause pain. Discogenic pain represents 85% of chronic neck pain. Next, the facet joints cause 10% of chronic neck pain. Facet joint pain is very common in patients with neck injuries and spine injuries. Facet joint pain is usually located on the sides of the spine, either right, left, or both. Facet joint pain gets worse with rotation of your head and neck, worse with extension. The most common facet joints to be injured are C5-6, C6-7, and C4-5. C7-T1 is another common facet joint to be injured. These joints, after injury to the capsule, will develop arthritis. It is the arthritis in and around the facet joint that causes the neck pain and stiffness with movement. Duke plasma rhizotomy is the best treatment in the world available for painful facet joints. Duke laser disc repair is the best treatment in the world available for painful discs. Other causes of chronic neck pain include fractures, tumors, infections, and muscle spasms. These other causes represent less than 1% of chronic neck pain. Thank you for joining us for 30 causes of chronic neck pain. Welcome back. You can see from our animation there are 30 common causes of neck pain, and the disc is 85 to 90%. About 85% of chronic neck pain comes from disc injuries. She has 2 discs that I believe are causing her neck pain. And the reason discs cause neck pain we're going to go into in just a moment, but it has to do with inflammation. Facet joints are the second most common cause of chronic neck pain, and we've already treated hers earlier today. All right, we're going to do a quick discogram and shot. You can see the tear in the back of the disc. Let's get another shot, Jordan. Shot. So the dye you can see is dark. It's very hard to see the tear but there's a tear back there. It's leaking the dye posteriorly. Yep. And so we're going to go ahead and place our guide wire through the needle. I know we have a question. We'll take that question in just a moment. Let me get into the disc before we take the question. In the meantime, Henry, show the audience, how do disc injuries such as a degenerated disc, herniated disc, bulging disc, how do they cause so much pain for the patient?
Of course.
Disc injuries start with an annular tear. Damaged nucleus pulposus herniates into the annular tear. The herniation triggers an inflammatory response within the annular tear. The inflamed annular tear generates pain signals. For more details, please visit our website at www.dukespine.com or call us at 1-800-FIX-MY-NECK 349-6963.
Welcome back. All right, can you see this, Henry? We've made a 4mm incision.
Yes, so you can, yes.
The incision on the neck is on the left side of the midline, and it is directly over the C6 vertebral body. Luis is helping us with a little tape measure. You see that?
Yes,
4 millimeters. Now I'm placing the dilator, and we're using the X-ray to guide us. You can see the dilator is going down through the soft tissues. The reason this surgery doesn't cause any complications like ACDF or disc surgery, artificial discs, is because it's a 4mm incision. We're not cutting anything except the skin. The skin is the only thing we've cut. And we're spreading the rest of the tissues. We spread them apart using the tip of the dilator, AP, Coker. And what that means, folks, is there's a technique in surgery where the surgeon, instead of cutting your tissues, can spread them apart. And by doing that, it's less traumatic, perfect, and it doesn't cause scarring or bleeding or difficulty swallowing or voice changes after the surgery. We've been doing this surgery now for 19 years. We've done 2,500 of these surgeries with an average of 2.5 discs per surgery. So that's over 6,000 discs repaired with laser. And by the way, not a single complication from the surgery. So that's amazing to have spine surgery without any complications in 19 years. But that's a testament to how safe this surgery is. You guys ready? All right. I'm going to need a gentle inline traction. Okay, the glare from this is just really affecting my ability to see the screen. Okay, that's better. Okay, let's go ahead. We're going to advance the dilator through the disc. Shot. And I know that people have questions. You got me inline traction? Yes. We're advancing the dilator to the back of the disc. By the way, Jordan, do some counting for us so the audience can actually see what level we are. So that's C2 with the arrow, 3, 4, 5, 6, 7. All right? Now we're doing 5, 6, 6, 7. Everyone agree? That's what we're consented for. That's what we're supposed to do. So I'm advancing the dilator to the back of the disc. This is a very degenerated disc. What that means is it's collapsed. Why is it collapsed? Because of chronic inflammation. Inflammation is a process whereby your body attacks something using its own cells called inflammatory cells, and the inflammation is your body's response typically to what's called a foreign body. Unfortunately, when your body creates inflammation in the disc, as you guys saw in the previous video, your body is looking at the herniation as being the foreign body. Why? Because like bacteria or pieces of wood or plastic in your body recognizes those things as foreign, not supposed to be here, and it attacks them. I don't make this stuff up. This is pretty standard, right? But why would it attack your disc? The answer is the herniation. The herniation is actually something called nucleus pulposus. Shot? Nucleus pulposus is the jelly that lives in the middle of your disc. It's a hydraulic jelly, but what it really is, it's a remnant of your fetal notochord. And it's tucked away inside your disc your whole life, basically since from trimester number 2 all the way to, being born in adult life. And the problem is that your body, when that nuclear material comes out through the tear, your body sees it as a foreign substance and it attacks it. Okay? That's what happens. So, by attacking it, it creates inflammation. Inflammation you don't want. I'm going to try to go a little bit further. Okay? A little bit further. Because, shot? Are you giving me inline, shot? Thank you. Any questions, Henry, in the meantime?
Yes, we have a couple of questions. This first one coming from Sam Said on YouTube.
Hello, Sam Said. Welcome. Shot?
Asking,
all right. Inline, one more time. Go ahead.
Asking, do you fix OPLL?
Great question. Do I fix OPLL? The answer is I cannot fix OPLL with a laser. Nobody can. It's not possible. But yes, I treat OPLL. The way I treat it, if you have OPLL, it's symptomatic, is I do a laminectomy, typically. And with the laminectomy, we decompress the spinal cord and nerves. It's very effective. If you have OPLL, you want me to fix it? Happy to do it. We do a very good job. It's done outpatient. You don't even go to the hospital. There's no bleeding, and there's minimal pain when I do it at Duke Spine. All right, tube is in. C6-7 bottom disc. We're going to do 5-6 next. But here is the rig. Can you see this, Henry?
Yes, we can.
We have the camera, the scope, the laser fiber, irrigation, light source. Light source. You see that?
Yes, we do.
Pretty cool, huh? And he uses fiber optics in two ways. One, to deliver light to the tip, but also to deliver an image from the tip to the camera. Keep the questions coming. In the meantime, Henry, let's show the audience how this surgery works.
Of course.
Disc injuries is a common cause of chronic neck pain. The inflamed annular tear causes neck pain. A 4mm skin incision is made. A small tube is inserted with no damage to the bones or soft tissues. The laser removes herniated disc fragments and debreeds the posterior annular tear. The annular tear heals on its own after it can take up to 12 months. For more details, please visit our website at www.dukespine.com or call us at 1-800-FIX-MY-NECK 349-6963.
Welcome back. So people are going to ask Dr. Duke, whatever inspired you to do what you do? Because, to be honest, not many doctors do discovery, new technology, ideas in medicine. They just kind of learn what they learn in residency and they just apply that to their entire career, and they don't really try to make new discoveries. And what it comes down to is the personality of the doctor, all right? Just like everything in life, it's personality that really drives potential for an individual to achieve things in life or not achieve. And what contributed a lot to my desire to be the best at what I do and to help people and is movies. I'm an 80s child. I grew up in the 70s and 80s. I was born early in the 70s, and I was a teenager in the 80s. And that was the time of the greatest movies that were ever made. For those of you who are young, if you ever get a chance, go back and watch the movies of the 80s, and you'll see 70s and 80s that those movies are incredible. They're made by brilliant directors like Spielberg and others, and the messages are very important. So one of the movies I'm watching now is with Robin Williams. For those of you who know Robin Williams, great actor, great person. He's deceased, but he had some really incredible movies, and the one that I'm watching now is called Awakening. And I watched it as a kid, right? I must have watched it. I remember watching it, and it inspired me. And the thing about it is that I haven't watched it. I don't know, what year was it made? Can you look that up, Henry?
1990.
All right, so I watched it in 90 when I was 20 years old, and it truly inspired me. And I didn't realize how much it inspired me until I'm watching it again at my house yesterday, and for 2 days now I've been watching it. The point I'm trying to make is I didn't realize how much of an impact that movie had on my career and my life's choices until I went back and watched it, 90, 2000, 2010, 2020, how many years is that?
35 years.
35 years later, I'm reflecting on my life and saying, how did I ever get to where I am now, doing what I do to help people, revolutionary things? And if you watch the movie Awakenings by Robin Williams, you'll understand. He was the same way. What a beautiful movie that was, huh?
It's not like my friend showed me that when during COVID, and it was heartbreaking. Like one of my favorite De Niro.
Yeah, heartbreaking,
films. Yeah.
but inspiring.
Inspiring, like unbelievably inspiring. And
Yeah.
I think it's based off on a true story. I don't know if the characters are real, but I know the story itself.
The story is real.
Yeah, very real.
And just for those of you who are wondering a little bit, it's about the use of something called L-DOPA. And dopamine was discovered as a drug that helped people with Parkinson's disease, okay, a neurological disease where there's not enough dopamine, which is a neurotransmitter found within what's called the substantia nigra of the brainstem. And what happens is you develop these motor and affect disorder. And the movie's not about Parkinson's disease, it's about something far more interesting, which is another disease that presents similar to Parkinson's disease, where the patients have Parkinsonian-like symptoms. And this doctor, who was hired by a hospital in New York, I think it was New York, yeah. And it's just an incredible story, but he decided that maybe the patients that were there that nobody cared about, everyone gave up on. Basically all the staff, all the doctors gave up on these people. They were just an inpatient psychiatric ward where they were just kind of existing. They were eating, they were sleeping, they had nothing in life to look forward to, no hope for cure. And this guy comes along, Robin Williams, he plays a doctor, a neurologist, who then decides that maybe these people are suffering from a Parkinsonian-like condition, gets a hold of dopamine because it was just released at the time. And there's some really good actors in there, and gives it to the patients. And of course, at first it didn't do anything. So I don't want to ruin the movie for you guys, but please watch Awakening. I think it's Awakening or Awakenings.
Awakenings.
Plural, all right?
Plural.
Amazing movie. And but again, the point is, for those of you interested, what inspired me to do what I do, to discover new things for people, to cure their pain, that movie was an inspiration. Robin Williams was an inspiration to me. And that's the kind of an effect movies had on people that grew up in the 80s. They inspired us to do great things. I wish movies today were the same way. But if you have somebody that you want them to be inspired and they're at an impressionable age in their teens, childhood, have them watch the 80s movies. And they'll grow up to be a really good person, I think.
I agree.
Yeah. Can't hurt.
Honestly.
80s movies were amazing. All right, any other questions from the audience?
Yes, we got a couple more questions.
Before you get there, I want to tell you where we are. We're at the back of the disc, and these are bones. Like, that's the bone of C6, and that's the bone of C7. The laser fiber is 0.5 millimeters. It's not even 0.5, it's 0.45. So it's half a millimeter wide. So that whole glass fiber you're seeing at 12 o'clock jiggling around is half of a millimeter. So look how big it looks. That's because of the endoscope. The endoscope is allowing me to see very small things very clearly, very magnified. And that way, these bone spurs, I'm removing bone spurs. That ridge right there is literally a bone spur. And I'm melting it away with a laser, okay? Right on top of the spinal cord. There's herniation right there. That's the stuff that's flickering around. So there's some more herniation right there. Got to float it out. And that's what we're doing. We're basically using the laser to vaporize herniation and bone spurs to get rid of the source of inflammation at the back of her disc that's causing all of her symptoms. So, got a few more minutes on this one, and then we're going to move to the next one. In the meantime, you have some more questions for me.
Yes, this next question coming from Charlie on YouTube.
Hello, Charlie. This is a bone spur, by the way. I just zapped away. People always ask me, can the laser remove bone spurs? Absolutely. As long as you know what you're doing with it. Go ahead.
Charlie asking, one of the things that worries me about ACDF is post-op dysphagia.
Yeah, you should be worried.
Is there less movement of the esophagus and the trachea needed with your procedure?
Yeah, Charlie, great question. So that's one of the things we don't have with this procedure. We never have post-op dysphagia or odynophagia, which is pain with swallowing. ACDF, it happens in every single patient. With this surgery, there is none. Why? The reason is simple. We're not cutting your neck open. We're not moving your esophagus over. We're not cutting the soft tissues. We're not creating trauma. So patients have zero post-op dysphagia and odynophagia. Odynophagia being pain, painful swallowing, and dysphagia being trouble swallowing, like not able to swallow normally. Solids, liquids. All right? So yes, this surgery has zero post-op dysphagia and odynophagia because we're not cutting you open, not doing trauma. I'm just going to get this last piece of disc herniation. You can see it right there. I'm working on it. It's somewhat calcified. All of this is totally degenerated disc. What does that mean? This was a herniated disc to begin with, right? She had trauma many years ago. That trauma caused a tear in the back of her disc in the wall. And now over the years, pieces of herniation have come out of the tear and are now pushing against her spinal cord, but more importantly, they're causing inflammation. All right, so we need to move the irrigation. Let's take it off one side and put it on the other. All right, thank you, Luis. Yep, we're working in a tight space here because her chest, we're very low in the neck. We're right up against the collarbone, and the collarbone is blocking me. So I had to shift an attachment on my scope from one side to the other to be able to finish what I need to do here. How's our irrigation? All right, what other questions do you have there, Henry?
This next question is coming from Denise on YouTube.
Hello, Denise on YouTube. Welcome to our live stream of spine surgery.
Saying, I'm being told that I need a C5-C6 disc replacement, and I'm really trying to avoid that. I want to send my MRI for review, but my case is work comp. Will you still be able to give me an opinion on my case?
So Denise, first of all, we take work comp. Second of all, your MRI review is free, and it doesn't matter what insurance you have. We do it for free. Even if you have no insurance or no money or anything, we want to help you get a diagnosis and give you a recommended treatment that is the best treatment for you. So yes, we take work comp. Our work comp guy in charge of work comp, his name is Richard. And Richard's phone number, if you want to call him, is 321-775-1860. 1860. His name is Richard. But more importantly, send your MRI to me and do the MRI review for him, and we'll tell you what else can be done instead of fusion, because these days you don't need ACDF anymore. With Duke laser disc repair, we don't need to do, look at that herniation right there. See it?
Yes, we do.
Right there. It's not floating out so easy because it's got calcium on it. So calcium makes it heavier. Calcium is what bone spurs are made out of, by the way, in case you were wondering. So anything that gets calcium on it, like these pieces right here, they don't float so easy because they're heavy. They're dense. We're called dense. They're dense. Their increased density makes them heavier, and they're really hard to get out. I got to blast them with the laser a few times, make them smaller. Look at the gold color. That's the calcium I'm talking about. That's basically a piece of herniation turning into bone. Okay. All right. So far, things are going well. I'm about 1 minute left on this disc. I'm going to go look at the other side again, and then we'll be done. Sorry. So was there another question?
Yes, there is another question coming from Sam Said once more on YouTube.
Yep.
Asking, how does laminectomies work, and will doing a laminectomy affect the structure of the spine, expose the spinal cord, weaken the vertebrae? Will it limit my movement or activity later on?
Yeah. So first of all, laminectomy is a horrible surgery. I never recommend it anymore. Do not do a laminectomy. Now that said, how do they work? We have a link. Yep. We have a link. Henry will give you a link right now.
Yes.
We need another stripper. Yeah. Sorry, we're not talking about a stripper like you guys are thinking. I just broke the laser fiber, compromised it, and the laser fiber has a plastic covering around it. And if you compromise the plastic covering, then the laser can actually come out through the side of the fiber. And it's called stripping the fiber. So that's what we're doing. All right. Did you find the crack? That was it? Yeah. So that's where it was, right up here, right? Correct. Yeah. So Luis identified where the laser was cracked and compromised. Now he's stripping it. He's taking the plastic off. Can you guys see that, Henry?
Yes, we do.
He's taking the blue plastic off, exposing the fiber. Here you go. Now we're going to run it down through the laser, for the scope, I mean. All right, but to answer your question, laminectomy, horrible procedure. They are literally going to take all the normal stuff out of the back of your spine. Okay? What's normal back there? You've got ligaments holding your spine together called the supraspinous ligament, interspinous ligaments, and ligamentum flavum. You've got bones back there. No, we're not done. I got just one more thing I want to check. You got bones back there called lamina. They're going to remove part of your facet joint, which is going to destabilize your spine and give you like chronic pain. Basically, the only reason doctors are doing laminectomy these days, in my opinion, is because patients always come laminectomy, you won't need a fusion. But once they do a laminectomy, your spine becomes so unstable, you're going to be begging for a fusion within a year or two. And that's what they want. They want to make it so that you're guaranteed to need a fusion. I know it's a horrible thing to say, but it's true. I've studied these laminectomy procedures. I used to do them all the time. They're horribly destabilizing, and more importantly, I did them only because I was doing a fusion. You do a laminectomy to get the pressure off the nerve roots. Damn it. We got water in the interface. All right, give me a second. One issue after another. So the water squirted out and got between the camera and the scope, and it's making it blurry, so I have to clean it. But that said, I would strongly recommend you don't do a laminectomy. Watch our video on laminectomy. It'll show you just how destructive it is, and people that get laminectomy have to take narcotic painkillers afterwards because the laminectomy is so invasive and damaging to your body. Okay? Strongly recommend against it. Laminectomy was a procedure originally done by a neurosurgeon named Victor Horsley. Dr. Horsley was British neurosurgeon in America. He was relocated to America, and he was at Johns Hopkins, I think, at the time. Long story short, he did the first laminectomy. It was done for a tumor in the spine. Okay? That's what laminectomies are done for, tumors in the spine. This should not be squirting up here. Okay? You have to be keeping that from squirting up because that's how it gets in the camera. All right, just about done. 30 seconds, and we'll be done here. Do not do a laminectomy. Watch our video on it. Strongly recommend you avoid it. It is not a good procedure unless you have a tumor and you need a laminectomy for the tumor. My advice would be avoid it. The long-term consequences are horrific. All right, that's it. We're done. Let me just check this side real quick. I see something hanging out there. Want to make sure we don't leave anything behind. There we go. That little piece there, all gone. Come on. There we go. Up and out. All right, done with one. On to the next. Keep the questions coming. Happy to answer them for you.
We have a question coming from Jay on YouTube
Yes, Jay, of course.
asking, can you get CRPS from compression on a nerve in the spine?
So the question is, can you get CRPS, which stands for Complex Regional Pain Syndrome, from compression on a nerve in the spine? So first of all, CRPS is poorly understood in terms of what causes it, but what we do know is that CRPS comes from basically a faulty sensory feedback loop that happens as the nerve exits the spine. So the answer would be yes, that can do it for sure. And what it does, we think it does, is it causes demyelination of the nerve, where the nerve loses its insulation, kind of like a wire losing its insulation. And then if you take the insulation off wires and you start touching them together, you get these short circuits, right? Where you get electricity flowing from one copper wire to the other because the insulation's gone. So if the insulation's gone from compression on the nerve root, then you can get what's called ephaptic transmission of impulses, one nerve to another, ephaptic, EFFAPTIC. And that's what they think is the source of CRPS. All right, let's get an x-ray. We're going to move up one disc shot. Is that it? All right, good. So I'm going to leave the dilator. I'm going to take out the tube. Now, the reason we have a little bit of bleeding is because bone spurs, right? You remember all those bone spurs I shaved down with the laser for her? Those bone spurs are filled with bone marrow. So when you start shaving down bone spurs, you're exposing the bone marrow to you in the surgical field, and the bone marrow is going to bleed because that's where blood comes from, is bone marrow. Shot? All right. We're going to come out of this disc. We're going to move up to the next one. Any questions, type them up. In the meantime, Henry, shot, if you want to AP, I think I'm off to the side. If you want to show a video on not the laminectomy. Every time we show laminectomy video,
Yeah, we get restricted.
we get shut down by YouTube.
Yeah.
It makes it so, okay, lateral. It makes it so that our video gets hidden,
Yeah.
okay? So they don't like seeing all that gore.
Nope.
But laminectomy is a gory procedure. All right. Shot, but go ahead. We're just about to enter the next disc, so you're welcome to stick around, or you can show them another video while we're navigating here.
We do have another question coming from Sam Said,
Sean?
once more on YouTube,
All right, let's get an AP. I got to see where we are. Go ahead, Sam said.
asking what is the best solution for the OPLL?
It's a laminectomy is the best solution. Cervical laminectomy with or without fusion. Right now, that's the best solution. Lateral. That's what I would do if you need it.
In the meantime, no current questions. Why don't we show the audience? We show
AP.
them how we cure herniated discs. Let's show them how we cure facets.
Sure.
Facet joint injury is a common cause of chronic neck pain. The inflamed facet capsule tear generates pain signals. The best treatment for facet joint pain is the Duke plasma rhizotomy. The inflamed facet joint pain nerves are destroyed. The advantages with the Duke plasma rhizotomy is that it's an outpatient procedure that takes 30 minutes to complete, very minimal bleeding and pain after the surgery with immediate recovery and return to work the next day, as well as a 99% success rate and permanent pain relief with a single treatment. For more details, please visit our website at www.dukespine.com or call us at 1-800-FIX-MY-NECK 349-6963.
Okay, take a look at the x-ray view on the lateral. You can see the arrow right at the tip of the dilator. That's the back of the disc. There's the tear. It's the black line right there. That is the tear called the annular tear. That's where all the pain comes from. That's what we're here to fix. Shot? All right. Keep the questions coming. Happy to answer them.
At this moment, no current questions.
All right, I'm going to go ahead and place the tube. Just so you guys see this, can you see the tube?
Yes, we can.
The whole surgery is done through this 4mm tube. That's why there's no swallowing problems. That's why there's no nerve damage, no scar tissue, no complications after surgery, because we are the most minimally invasive surgery in the world for spine issues for the disc. Shot? All right, again, I'll use the x-ray. Let's count 2, 3, 4, 5, 6. Everyone agree 5, 6? Yes. All right, little inline. Here we go. We're going to enter the disc. Shot. I got to make sure I don't advance the tip of the dilator as I slide the tube down the dilator. The dilator is in position. Luis is watching the dilator to make sure it doesn't move, because the tip of the dilator is at the back of the disc. Just a little movement there. Yep. All right, I'm going to advance the dilator because it's come backwards. Shot. We need it to be in there, otherwise we'd be biopsying the disc. We don't want to biopsy the disc. That's not why we're here. That's looking good. Any questions?
Yes, we got a couple questions. This
right.
next two is coming from Denise on YouTube, asking what exactly is the rhizotomy and how does plasma help? And how long typically is a surgery like the one you are performing right now?
This surgery takes me about 45 minutes to fix 2 discs. And if you count the time that we put her to sleep to put the tube down and the time that we take to take the tube out, it's probably an hour and 15 minutes for everything. So we bring her in the operating room, we put her to sleep while she's laying on her back, they put the tube down. That's what you're seeing on the x-ray is the endotracheal tube and the esophageal temperature probe. And then I do my surgery, and then I'm done. I put a little Band-Aid, and then they got to wake her up, and that waking up may take 15 minutes, and then we take her out. She takes an hour to recover after that. So the surgery is an hour and 15 minutes. As far as plasma, what is the Duke plasma rhizotomy? Rhizotomy means to cut a nerve. The nerve we're cutting is the pain nerve. We want to do a rhizotomy. We want to cut the pain nerve. Unfortunately, RFA doesn't do that. My technique does, because we use a wanding. That wanding is patented, and that's why only Duke Spine Institute can do it, because we're the ones who discovered it. I want you to look carefully at the color of this tissue. This is pink. It's pink because of inflammation. Inflammation makes tissues pink, right? Your zits are pinkish red because they're inflamed. This is supposed to be white, but it's pink. All right, this is where her pain's coming from. We want to zap all this stuff away with a laser. Now, it's pink because her body's attacking this area, trying to heal it. Because you see right there, that blue thing at the bottom of my laser, that is the herniation stuck in the tear causing the inflammation. You see how the laser got rid of the inflammation? And look at that piece of herniation down there. Right there. It wants to come out. All right, it's just jiggling around. But that's what herniations are. It's not one piece, it's many pieces. Plus you got bone spurs back here. So I'm using the laser to zap this thing, make it smaller, because it's too dense and heavy to come out right now. We want to float it out. To make it float out, we got to make it smaller. There it goes. We just float it out. It's kind of like one of those ghosts in Ghostbusters, right? All right, I hope that answers your question in terms of plasma. The plasma we're using is electrons. It's not your plasma from your blood. We don't use platelet-rich plasma. It's not a PRP procedure. The Duke plasma rhizotomy uses real plasma, and that plasma is high-energy electrons in a vapor form. That's vaporized water electrons. They get vaporized at the tip of my Duke plasma wand while we're doing the procedure. All right, great question. Hope I answered it for you. So here's that herniation. The nucleus just stuck inside the tear in between the two bones at the back of the disc, causing all that inflammation. By the way, the laser is 0.5 millimeter wide, 0.5 millimeters, 0.5 millimeter, 0.5 millimeter, just to give you an idea of what you're seeing here. Everything is very small. So if that fiber, the glass fiber, is 0.5 millimeter, then that bone spur right here that I'm working on is about 0.3 millimeters. So that's take a millimeter and make it into a third. That's what we're dealing with. Very, very small things. A lot of the things we're dealing with aren't even seen on the MRI. You can't see these things on the MRI, by the way. That's why a lot of doctors have no clue what causes pain, because the source of the pain is so small, it's not even visible on an MRI. A lot of scar tissue here where the herniation is. All right, keep the questions coming. Happy to answer them for you.
Yes, next question coming from the Classic Carnut on YouTube.
All right, welcome back, Classic Carnut 2025.
Asking, what are your thoughts on non-instrumented lumbar fusion? I have a family member that has arthritis and bone growth and thinks the DLDR might not work. I asked him to do at least do a free MRI review with you.
Well, Classic Carnut, you are correct in that they should at least do an MRI review. There is no condition that I know of in the spine that the Duke laser disc repair will not work for. That is disc-related pain. All right. And I cannot get my tube in the disc, which is very rare. It does happen, but it's extremely rare. It's about 1 in 200. If you have a huge facet and you have a completely collapsed disc and there's no movement at all, it's possible I can't get in there to fix it. But 99.999% of the time I can get in there and fix the problem. So when people say, I don't think Duke laser disc repair is going to work for me, that's great. You have your own opinion about it, but it is the wrong opinion. All right? Only I can have that opinion whether it's going to work or not. And I mean, I can tell you probably 1 in 200 patients that it's not going to work. That's how rare it is. So I suggest they do what you say, which is do the MRI review. I'll tell them if it's going to work or not. Now, here's the truth, though, okay? When I do MRI reviews with people, right, if you ask the person I'm doing the MRI review with and you say, what's causing your back pain? They'll tell you, most of the time, they'll tell you what's causing their back pain, right? They'll say it's my bad disc at L5-S1 or L4-5. But guess what? They're wrong 99% of the time. So it's funny how people have an idea of what's causing their pain, yet they really don't know what's causing their pain. They just have an opinion. But their opinion is wrong. And I'm not saying this to sound arrogant to you. I'm saying this because I want you to know, even when you think you know, you really don't know. You really need somebody like me to tell you what's causing your pain. And the problem is they go see a doctor, chiropractor, primary care, surgeon, and the surgeon says it's L5-S1. But it turns out it's not just L5-S1, it's L4-5 too. and it's also the piriformis muscle, and it's also the SI joint. By the way, the surgeon missed it. So the problem in America and the rest of the world is that it's the diagnosis of what's causing the symptoms. I got 3 minutes left.
Thank you.
The diagnosis of what's causing the symptoms is the biggest problem. We are horrible as a country, as a world, at diagnosing the cause of back pain or neck pain. Now, Duke Spine Institute literally is leading the world, and the reason we are is we have something called the Duke Spine exam. The Duke Spine exam gives you the diagnosis, and it's 99% accurate, okay? 99% accurate. Those are our numbers based on diagnosing thousands and thousands and thousands and thousands of patients with back pain, okay? And not only diagnosing them, but fixing them by treating what the diagnosis is. So by treating the diagnosis and curing the back pain, we know the diagnosis was right. That's why we have that data. We have that knowledge. We have that experience that nobody else has, because we've cured back pain for so long, or literally 20 years. So when people say, oh, my pain's coming from L5S1 or whatever, I always say it could be, but you may have other sources. So let's talk about that for a minute. Turns out, how much irrigation's left? I think we're all right. Let's just leave it. I think we're good. I'm almost done. Yeah. So I'm going to answer your questions more completely when I get over there. All right, but we're pretty much finished here. I've just got to float out these last few pieces of herniation. How much is left? It looks like we still got a little bit. But it is pretty dead. I think we're done though. So, well, let's do a little more irrigation. I want to get this last bit, and I think we're completely out. So I need a little bit more. There's a little bit of disc herniation left over here. Go ahead and spike it. You guys see the little fumaroles, the little bleeding coming from the bone?
Yes, we do.
Okay, you don't see it normally because we have irrigation. Irrigation is the flow of liquid. Without that irrigation, the surgery is not possible for two reasons. Three. Number one, we can't see because there's blood. Number two, the laser would overheat everything in there. You need that irrigation to cool the laser, okay? Because it's cold irrigation. And number three, every time we release a piece of herniation like that right there, it's got to float up and out. You don't see it. It happens so fast. But those pieces are floating out, okay? By the way, there's the posterior longitudinal ligament. Those fibers right there, the PLL, for those of you who know what the posterior longitudinal ligament is. Right behind that is the spinal cord, okay? There's bone spurs. Those are not doing anything. But I need 30 seconds and we're done, guys. 30 seconds and we're done. Okay, Berndes? I'm going to come and answer your questions face to face. Type them up because it's a new year. This is our second surgical day.
This
But
is
the
our
last one,
Yeah.
we didn't live stream because our system was broken.
Yeah.
Our live stream system was broken.
So, in other words, this
This is our first live stream day of the year, 2025.
Exactly.
Yeah.
Exactly.
So I'm going to come and answer your questions face to face, and type them up. And this is it. I'm just zapping the last piece of herniation on the patient's right side. There it is. Look at that. Beautiful. Got a little bit more and we're done. See it? Moving around there, jiggling. Yep, there it is. But look at that thing. It's so big, I'm going to have to cut it in half. I can't even grab it out. Luis is handing me the grabber, which he's right. That's the right thing to do. But it's too big to grab out. And it's kind of tucked down into the crack. So I'm just cutting it in half or cutting it in thirds. And I'm going to float each of these herniation pieces out. You see the gold color? That's the calcium I was talking about.
Yes, we do.
The calcium makes it heavy. But calcium is what your body does when you have abnormal tissue, like a herniation. We're done. Yeah, we're done. We're done. I'm just floating. Look at all the pieces I had to float out. And let's see what's left. Maybe one or two more. Type your questions. We're done with this lazy laser. Laser surgery, laser spine surgery done at Duke Spine Institute here in Florida, leading the world in spine surgery. By the way, if your surgeon's talking about ACDF, he is literally now 50 years behind in technology. I used to do ACDFs all the time many years ago, and I'll be honest, they pay a lot better for me than this type of surgery does. So it's purely an economic thing for most doctors. They make the most money doing your fusions or disc replacement, but that's not what's best for you, the patient, okay? I did these surgeries for years without making any money at all. I had to pay for the surgeries to be done from my patients because I never got any money. And I don't just mean my money, I mean the facility money. We basically paid for people's surgeries, hundreds. And I got really good at it. Of course, it's not a viable way to run a business is to pay for people's surgery, but I had no choice at the time. We're done. It was either do fusion and get paid well, or do laser and get paid nothing and actually pay for their surgery, or go out of business. So I did fusions on some patients that wanted it. I did lasers on those that wanted it. And here we are 19 years later, and there's a huge demand for the surgery because of its success rate. All right, type your questions. We're done. I'm going to just show you the small incision. I'm sure you guys can see it.
Yes, we can.
And here we go. By the way, we published the first paper on this surgical technique, Duke laser disc repair, 13 years ago now. Surgical Neurology International, peer-reviewed, published. The chief editor-in-chief is Dr. Osman. He was the professor emeritus, basically the chairman of neurosurgery at UCLA. Very respected neurosurgeon. I was very impressed with this technique. He's retired, and Dr. Nancy Epstein has taken his position at the journal. Anyway, you can see, look how small the incision is. It's tiny, folks, tiny. And normally we don't lose any blood, but today we had a little bit just because of the bone spurs we had to remove. There were so many. And removing bone spurs causes some bleeding. All right, scope use was a 7. No, 8. 8. Thank you, Luis. Thanks, everybody. Great job. I'm coming to answer your questions. Type them up. And good morning, I'm Dr. Duke Machen at the Duke Spine Institute. I'm here with my patient who traveled to Duke Spine Institute with a couple of problems. She had neck pain from a herniated disc and facet joints, and we fixed both yesterday. She's here less than 24 hours after her surgery. She went home, back to her hotel with her family afterwards, and she came back in for a quick checkup. You can see the incision for her surgery is 4 millimeters. It's tiny. How do you feel today?
I feel good. A little sore from surgery, but that's normal. I'm so much better. I could just feel that I've been fixed, and that was not gonna happen without you.
Well, how did you hurt your neck?
I got into a motorcycle accident back in October, and it flew off the bike.
And you've been suffering since then?
Yeah.
Why did you decide to come to Duke Spine Institute?
Do you have enough time?
Sure.
I came here because I was told that I had to have this really invasive surgery. They wanted to do a discectomy.
And fusion.
Yeah, and I was very scared. I was very scared, especially after reading what could happen, the risks. It was just too much, and actually kind of scary because when I looked into the doctor, he actually had a lawsuit against him, which the people who suggested him to me were not aware of. So I kept doing my research. I thought, well, maybe I'll just figure out how to do some exercises to help my herniated disc, which, yeah, now that I know what I know, that's not gonna help your herniated disc. Nothing is gonna put that stuff back in your disc.
That's right.
So I did 6 months of physical therapy. That was unsuccessful. I still had pain in my neck and it was really bad. I would turn my head anyway and I would always feel the pain right here, feel the pain in my C6. I couldn't do the things I normally did. So when I did my research trying to look for exercises I could do to help my disc, he popped up on my feed and said, "Do you have a herniated disc? I can fix you." And the more research I did, I was just so thrilled because nobody has his impeccable record. No one. That's why I went to him. He knows what he's doing. He is crazy confident. His staff is amazing. They're so kind. They're so attentive. The lady that did my IV was so gentle. She did it and I was like, "You're done already?" The people here are amazing. This doctor knows what he's doing. God has his hands in his hands.
Amen. We are so thrilled that you were able to get your neck fixed here and avoid that metal plate and the fusion and the discectomy, which is totally unnecessary, by the way. I'm trying to help people understand the truth. There's no need for ACDF fusions anymore for degenerative disc conditions. We can fix it with the Duke laser disc repair and the Duke plasma rhizotomy. You can see in your video here, we went into your disc, we used the laser. We actually pulled out several big chunks of herniation. I don't know if you watched your surgery, but you could see them coming out from the back of the disc. I cleaned the back of your disc beautifully, got the foramen opened up. There was nothing in there when I was done. Now your disc is going to heal naturally without any problems. Is there anything you want to tell the rest of the world out there that you haven't already said?
If you're in any kind of back pain, any kind of neck pain, he's the only option because he knows what he's doing. Really, he can help you. He's helped people get out of wheelchairs. He's helped people be able to ride horses again. I mean, I'm gonna be able to go back on a jet ski. I'm gonna be able to go back to my life. Obviously not right now after my healing time, but I wasn't gonna be able to have that happen before. And I'm an adventurous person. So if you're an adventurous person, if you're in pain, if you want your life back, you need to come here. You need to come here. You will never regret it. You will never look back. I promise you with all of my heart. He's the one you need to be with.
Well, congratulations on taking the faith and getting it fixed.
Thank you. Thank you so much.
You're welcome.
You've made me so happy.
You have a beautiful family. Please tell your husband I said hi. He's a very smart man.
Absolutely.
And I'm very happy you're doing well.
Thank you so much.
You're welcome. All right, take care.
You too.
Let's get you out of here. And good morning, I'm Dr. Duke Majin, CEO and founder of the Duke Spine Institute. I'm here with one of my patients who traveled from California with a problem in his neck. He's been having pain, it radiates down into his left arm. He has some other issues as well, like pinched nerves in the elbow and palm, which he's treating in California. But the herniated discs at C5-C6, C7, we did the Duke laser disc repair yesterday. You can see me going in with the endoscope and the laser. It's all done with a 4mm incision, bloodless surgery, and outpatient. And here he is less than 24 hours later, and he wants to share his story with you. So go ahead.
Okay, so the first thing I want to do is give Dr. Duke, he's going to understand this. We might have to look some of these things up. A neurosurgeon was performing several radiofrequency ablations on patients when he started hearing loud shouts and screams in the recovery room. Shocked, he walked into the room to see what happened. The nurse ran up to him. "Doctor, things got pretty heated up for a while, but no one had the nerve to say anything." That one over there seems especially nerveless. All right, so I got him to laugh.
I like
Good
it.
stuff. Okay.
I like it.
You know, just a
Nerveless
little
instead of
dad
nervous.
humor there. Good
I love
stuff.
it. I love it. I love it.
What happened for me was ever since I was a kid, I was the young kid that fell off the high chair when I was 2 years old, fell down the staircase when I was 4, got tripped, hit the back of the sandbox at 6. I went in the military, I parachuted out of planes, hit my head more than once with a Kevlar helmet, then served in the military wearing Kevlar helmets, sometimes banging my head against heavy artillery pieces. Sometimes I didn't have my helmet on. Sometimes just the weight of the helmet was hurting my neck and my back.
That part about banging your head in the plane against heavy artillery pieces, sometimes you hear in the military like a helicopter went down, right? Suddenly exploded, went down. Now I know why.
Well, I mean, people will say, why would you jump out of a perfectly normal airplane?
Right.
But, let me just tell you, low contour flying by sea, some of the jets there makes things a little bit tough. And then after that, what I started to notice, I started to develop where my muscles in the back just became really severely tense and stressed out. I kind of thought it was work, and otherwise. And then when I'd go to things like the dentist and I'd lean my head back, my entire left arm would just start tingling and sparks shooting out like crazy. And when I got back up, things were better. But then I went on a trip back in early May, and then it was happening all the time. At that point, I got an MRI done. Obviously at that point, I went to my primary care and I had options. There were 5 options really, if you think about it. One was do nothing, just, hey, I'm getting older, just deal with it, stop being a baby and just, life goes on.
Okay, well, I hope you enjoyed that testimonial from one of our patients who happened to be a veteran. We love our vets, tremendous respect for them all. I wish I could fix all of them. Someday, hopefully, if the VA system gets fixed, and the VA system needs to get fixed. I'm going to answer your questions in a moment, but I want to digress for a minute. Many of you know I produced, with Henry's help, a video recently that talks about denials in health insurance. So what does that mean? It's basically when your doctor recommends a treatment or a test for you, the patient, and your insurance company says no. And the way they say no, they can't just say no. It's against the law just to say no. They have to give a reason. And the reason they give, the one that they love giving, it's their favorite reason, and it's just complete bullshit all the time, is they call it experimental or unnecessary, the test or treatment. They put it in a letter and they say your doctor recommended unnecessary test or unnecessary treatment. Don't you love that?
Yeah.
So it really builds confidence between the patient and the doctor. But the truth is, the test is necessary, the treatment was necessary. Your insurance just doesn't want to pay for it because they want to keep the money. If they keep the money, that means their profits are higher every year. Well, the VA system works differently. The VA system gets funding from the taxpayers, and it gets funding from the government allocated to the VA system to pay for medical care for our active military and our vets. Here's the problem. I worked at the VA hospital for 7 years in Gainesville, second busiest VA hospital in Florida. Busy hospital. I will tell you what's really happening at the VA. The truth, the God's honest truth, is absolute corruption at its finest. The VA doesn't deny treatments. The VA will go along with whatever treatment I recommend. The way they save the money, all right, because they're all about saving money, the way they save the money is by having us see as few patients as possible, having the doctors treat as few patients as possible. So how do they do that? Well, number one, they take the clinics where we see the patients in the clinic, and instead of us seeing 20 patients in the morning and 20 patients in the afternoon, which we could do, that's 40 patients a day, they restrict the number of patients we can see to about 5 in the morning and 5 or 6 in the afternoon. All right. And the way they do that is they say, oh, the staff have to go home at 3 o'clock. Now, the second thing the VA does is they restrict the number of surgeries we do by starting the surgeries later in the day and making us be finished by 3 o'clock. Okay, that's the policy. Most people don't know about these policies. They're hidden from the public. The reason, if I want to operate on my patients at any other hospital, I could operate till 10, 11, 12 o'clock at night. I could operate all night if I had the volume of patients. At the VA, they prohibit you from doing a surgery unless you're going to be finished by 2:30 or 3 o'clock latest. Now, what neurosurgery procedure can you really finish by 2:30? Almost none. So that basically forces us to do one surgery a day in the VA. And they only give you neurosurgery. They basically look at your surgery, like neurosurgery is expensive for the VA. So they say, oh, you only get 1 day a week. All right. Whereas cheapo surgeries like bunion surgeries for foot doctors, they'll give you 5 days a week. They have all these sneaky little tricky ways to keep the vets from getting the care they need. So when we get vets at Duke Spine, we bend over backwards to do everything we can to fix our vets. All right, Henry, you've got some questions.
We got a lot
of
Henry
questions.
says we have a record number of questions today.
Yes.
We've been doing these streams for 10 years, folks. 10 years we've been live streaming our surgeries just like this. And it used to be fusions in the old days. You go back and look at our YouTube channel, you'll see thousands of fusion surgeries. But now we do laser and plasma, much better for the patient, safer, faster recovery, and better surgery results. So what do we have for questions?
These first three questions are coming from Denise on YouTube.
Hello, Denise on YouTube. Welcome to our live stream.
First question asking if the disc is already degenerated and herniated and gets fixed with the Duke procedure by laser, would it be likely that in the future a disc repair would still be needed as the disc is already thin?
Yeah, Denise, great question. I know it's hard for most people to understand here, and honestly, it doesn't really make much sense, does it? Like if you think about it, the disc between the bones is collapsed, it's degenerated, there's bone spurs everywhere, it's just destroyed, right? But the reality is, what do people want? They want to get rid of the symptoms, period. They want to get rid of the neck pain, the headaches, the pain going into the shoulders, down the arms, the numbness, tingling, weakness in the arms. People want to get rid of their symptoms. And surgery is all about getting rid of the symptoms. That's what we do. And so the laser surgery we just did, it gets rid of the symptoms, but the disc still looks the same. It looks ugly. If you get an MRI, it's going to be degenerated. Now, will the patient need additional treatment for the disc? Absolutely not. How do I know that? Because I've done 2,500 of these surgeries in the last 19 years. And the average number per patient is 2.4 discs. So I've done 6,000 plus discs like this with a laser in the last 20 years. And patients do not come back ever. The pain is gone and it's permanent. And by the way, these people pay cash. Most of them pay cash for their surgery. Okay? So these surgeries are not cheap. They're very expensive. We don't charge the patients the full amount. We charge their insurance, but people pay a lot of money for the surgery. So believe me, if it doesn't work, I'm the first person to hear about it. Or if the pain comes back, I'm the first person to hear about it. And it is very, very, very rare that the pain ever comes back. As a matter of fact, it's 1%. 1% of the patients will re-herniate their disc, re-injure their disc after I fixed it. They know they did it too. They'll tell me, Doc, I was stupid. I was lifting some furniture and I felt a pop. And then the pain's back, all right? So it literally happens. In the 2,500 patients we've done, we've had 25 patients re-herniate. And they come back and they get the surgery done again and their pain goes away. So does the Duke laser disc repair, does it work? Absolutely. It doesn't matter how bad the disc looks or how good it looks. It works. And number two, does it last? Absolutely. It lasts a lifetime. It could last 30, 40, 50 years, depends on how long you live. And it never comes back, the symptoms from that disc. All right, next question.
Next question from Denise, once more on YouTube, asking, is there a big difference between disc degeneration and disc desiccation?
So is there a big difference between disc degeneration and disc desiccation? Degeneration is a radiographic finding of the disc. It's a finding we see on MRI or X-ray, and it's basically includes desiccation, which is a drying out of the disc. But it also includes bone spurs, irregularity of the end plates, kind of waviness from being eaten away by inflammation. It involves also collapsing of the disc, so loss of height of the disc. So, and then herniations, bulges, bone spurs sticking out, thickening of the ligaments, thickening of the tendon. So basically, disc degeneration involves more than just desiccation, but desiccation is part of degeneration, but there's other findings as well. Desiccation just means drying out.
And then coming from Denise once more on YouTube, asking if you need to come in out of the state for a procedure like the one you are doing right now, how long do you need to plan to be in Florida pre and post-op for diagnostic and treatment?
Yep. So Denise, great question. 80% of our surgical patients come from out of Florida, out of state. Probably about 10% are out of the country. 70% are out of state, but in the United States, and about 20% of the patients are from Florida. So for those patients coming from other places, they need to be here for 3 days. That's it, 3 days. We can do everything in 3 days. The first day, say Monday, you're in clinic, you meet the doctors, you meet me, Dr. Berndes, the anesthesiologist. We do paperwork. You meet Remy, you meet the team, and we do a history physical. We submit prior authorization for your insurance, prior certification for medical necessity. We go over the DME or back brace, neck brace that you're going to need. We go over restrictions. We just do a lot of educating. And then day 2 is your surgery, and then day 3 is quick checkup, and then you can fly home. So really, it's 2.5 days. 2.5 days you need to be here. But we have, of course, expedited programs. If you want to fly in, get your surgery done that day, and fly out that night, we could do that too. So technically, I mean, not many people want to do that, but one day is all you really need. One day.
And the next question is coming from, I love the name, Not So Boring on YouTube.
Not so boring on YouTube. Welcome.
First question asking, is there something special to the use of the laser compared to more traditional instruments? Patient asking.
Yeah, great.
I think the second question is a follow-up. Isn't repair a bit loose?
Yeah, so the question was the laser, is it really necessary, or, are other more traditional steel instruments that we use, could they be used? The laser is absolutely essential to the procedure. The procedure cannot be done without it. It would not work. The laser is absolutely essential. Number one, why? Because the laser, number one, is very, very small. I know the picture you're seeing, it looks big, but that laser is half a millimeter wide. So what we're doing is we're using the endoscope to blow up what we're seeing in there, to make it big, magnify it, and illuminate it. The endoscope magnifies and illuminates, but what we're seeing is like those little bumps you're seeing are a tenth of a millimeter big. No surgeon without the endoscope can see them. They are not visible. And there's no surgical instrument that can fix them except the laser. It has to be precise, it has to be small, and that's the laser. Also, the laser is so efficient at doing its job. I mean, it literally is 100 times faster than the other instruments. The other instruments would take hours to do one surgery. The laser gets it done in minutes. It is incredible. The laser is absolutely essential, cannot be foregone in this treatment, is required. That's why it's called the Duke Laser Disc Repair. That's how important the laser part is.
These next 7 questions are coming from MSM on YouTube.
MSM, welcome to our stream. 7 questions. I think that's a record.
That is a record.
So we're going to bang these out. Let's go.
First question asking, can disc tears cause thinner discs? Example, if I had a single side or front disc tear causing my disc to become thinner over time, would you fix the side/front tear?
Yeah. So first question, great question, very insightful. MSM. MSM has picked up on something important. We only fix the tears in the back of the disc, not the sides, not the front. Why is that? The answer is simple. Number one, the tears in the back of the disc cause pain. The tears on the sides and front never, ever, ever cause pain. And there's that are pain fibers transmit up to your brain to an area that's called the primary somatosensory cortex. It gives you a feeling of sharp, severe, localized pain. The nerve fibers on the side and the front of the disc do not go to the primary somatosensory cortex. They go to the brainstem, and those give you really no pain. So we don't treat tears on the front and sides. As far as thinning of the disc, thin discs are fine. There's nothing wrong with a thin disc. A thin disc is like a thin nose. If you have a big nose, it's a big nose. If you have a skinny nose, it's a skinny nose. It's still a nose. It still works just fine. Thin discs work fine.
Follow-up from MSM. If the side front tear won't be fixed and the disc continues to become thinner until no disc is left, then fusion would be needed, correct?
No, fusion is never needed. no matter how thin your disc is. This is the follow-up question from MSM. Yeah, it doesn't matter if you have 0 disc left. If you have 99% gone, all right, you do not need any treatment whatsoever. The absence of disc material does not cause symptoms. It is not the absence of disc material that causes symptoms. If I take a normal disc and suck all the jelly out, collapse the disc down to nothing, you will not have any symptoms at all. It is the tear in the back of the disc that causes symptoms. That's what I discovered at Duke Spine. That is my work, my life pioneering work, and that's why we do the Duke laser disc repair and clean the tear. As far as a repair is the right word. I don't know what other word we could choose. It's really a debridement, but also it includes decompression. So disc repair is probably the best choice of words, in my opinion.
Next from MSM asking, what factors sped up adjacent segment disease after fusion?
So great question from MSM. What factors speed up adjacent segment disease after fusion? The answer will shock you. It is the surgeon. It is poor surgical technique that is the cause of adjacent segment disease. And what I mean by that is fusing you in an unnatural alignment is the number one reason. Number two, if the surgeon compromises the adjacent joints during the surgery by cutting into them or by cutting them or damaging them in any way, that's going to speed up adjacent segment disease. Here's why I know that, because I used to do fusions. I've done thousands of fusions in my career. And I was a very good fusion, probably one of the best in the world, if not the best at fusions. You can watch my fusions on my video. Why do I say that? I say that because my patients had the best results. That's why. You can call yourself the best fusion surgeons when your patients have the best results. So what are the best results? One, elimination of pain in the back or neck, wherever you're fusing. Number two, elimination of pinched nerve symptoms like weakness, numbness, tingling in the arms. Number three, low complication rate, very, very low complication rate. Number four, fast recovery, very fast recovery. My patients recovered in 1 hour. They went home an hour or two after their fusions. They never stayed in the hospital. We do it outpatient. I was the first in the world to do multi-level fusions outpatient. Not the first to do single-level fusions, the first to do multi-level fusions outpatient, send patients home the same day. And we still do that. You can watch my videos from 10 years ago. All those patients go home the same day. So what makes adjacent segment disease is poor surgical technique. Next.
Next question from MSM asking, after Duke laser disc repair, will discs ever get thicker again after they heal shut? Also, do discs fully heal shut after the Duke laser disc repair?
Yeah. MSM, you've got incredible questions. Thank you for participating. I think everybody's benefiting from these questions and answers.
Yeah.
So 2 questions. One, will the disc ever fill back up after the Duke laser disc repair? Absolutely not. There's no treatment in the world that makes your disc fill back up. None. Number 2, will the disc actually heal itself? The answer is absolutely yes, it does. And the reason it heals is because we're cleaning the tear in the annulus. The annulus wants to seal. It cannot seal because the jelly is stuck between the sealing fibers. I go in there and clean out the herniations, clean the tear, debridement, and that allows it to seal. It does seal, but it takes 9 months to a year.
Next question, MSM asking, what's different about the Duke laser disc repair compared to all other endoscopic laser methods? What makes the Duke laser surgery special and different?
Yeah. So what makes the Duke laser disc repair different than all other endoscopic treatments? First of all, I don't perform all other endoscopic treatments. So somebody could be out there doing something I don't know about. But the endoscopic treatments I know about are far more invasive. They're more damaging to the patient. A lot of the endoscopic surgery done is done with 2 ports. So it's called biportal. And we use a single port. So single incision, single tube. Far less invasive. The other biportal techniques that you hear about for endoscopic surgery, those surgeons are drilling away, removing bone and ligament out of your spine. You do not want that done. My technique does not remove any bone or ligaments out of your spine. There is no damage at all to your body with my surgical techniques only the skin. The skin is the only thing that's cut and damaged. Everything under the skin is preserved through my Duke laser disc repair. Other types of endoscopic surgery, the surgeons are cutting bigger incisions, they're cutting through the muscle, cutting through the bone, cutting through your ligaments, cutting part of your facet out. So they're damaging the inside of your body, which is why patients have so much pain afterwards. After other types of endoscopic surgery, you have pain, you have to be on painkillers. With my patients, they don't take painkillers. After surgery, their pain is completely gone. 50% of my endoscopic patients have zero painkillers whatsoever. The other 50% take Tylenol, and that's it. So our surgery is painless because we don't cause damage to inside of your body. There's a lot of other things. They don't do a annular debridement. We do. We're the only ones that do the annular debridement. It's the most important part of the surgery.
Next question, MSM, asking after full recommended treatment, for example, after having a Duke laser disc repair, what percentage of patients have symptoms return after a long period of time? Example, 5 to 20 years. Are there studies done?
Yeah, so MSM, first of all, there are no long-term studies for any spine surgery, but we do have long-term studies for our surgery. We have 5-year follow-up, and the average amount of pain relief is 95% at 5 years, average 5 years follow-up. So that is long-term. But other types of spine surgery do not have 5-year follow-up. You will not see anything. Does the pain return? Absolutely not. Once you fix the disc properly with the laser surgery, the pain never comes back to that disc. You may get pain somewhere else from some other body part, but not from the disc.
And then lastly from MSM asking, are there phone, Zoom, email, paper survey testimonials of patients 3+ years later after getting fixed? If the testimonials don't exist, why? Thank you.
Yeah, great question. So why are there not testimonials of patients 3 years later? The answer is simple. If you have a doctor fix your problem, do you go back 3 years later? No. As a matter of fact, our patients come here, they get fixed, and then they disappear. We don't hear from them ever again. Why? Because their pain is gone. Sometimes they respond on Facebook or YouTube and say, you fixed me 3 years ago. I'm doing great. Thanks so much. But generally speaking, you don't have 3-year follow-up because the patients have moved on with their life. Their pain's gone. They're not coming back to the doctor. That's it.
And then we got a lot more questions coming from Not So Boring, once more on YouTube, asking, is this a medical institution or just a company?
Duke Spine Institute is a clinic.
Yeah.
We treat patients here. We're a doctor's office. We're a surgery center. We have an MRI scanner. So we're a full service spine clinic, and we're here to treat patients that are having back or neck pain.
Coming from Classic Carnut, once more on YouTube, saying, hi, what are your thoughts on non-instrumented lumbar fusion, as mentioned before?
Yeah, sorry.
Yeah.
Yeah, non-instrumented lumbar fusion is not something I would recommend to too many patients. You know, your question is very difficult to answer. When I did lumbar fusions, I always did instrumentation because the results with instrumentation are much better. The patients do better. They get better relief of their pain and symptoms. They have long-term stability of the spine. All right, especially with my technique where I do osteotomies, I'm removing their facet joints, which are normally pinching the nerves, causing neurogenic claudication and radiculopathy. If you want to decompress the foramen, you want to correct their alignment, you need to remove the facets. You need to do instrumented fusion in that case. Otherwise, the spine would fall apart. So, my personal bias, and I truly believe this is the right way to do it. I've published my results. You can go look up my paper on transforaminal lumbar interbody fusion, Dr. Ara Duke-Majan on PubMed. It's been peer-reviewed and published. And my average pain relief was 85%. That's unheard of with fusion. Most surgeons have 50% at best. I had 85% on average. I have many with 100. And that's with lumbar fusions, with instrumentation.
Next, coming from Not So Boring, once more on YouTube, asking, what about the use of injection to rehydrate the disc and promote regeneration? I think
Yeah.
they're asking, do you promote that? Support
Yeah. So, what was the name
that?
again?
Not so boring.
Not so boring. Sorry. There is no product available in the world that rehydrates the disc and refills the disc. Okay. There are products, they don't work. I would not do them. They are unnecessary. Um, I get this a lot from people. They want the disc to look normal again, to be full and fat. You have been lied to. The disc being full and fat and normal looking is totally unnecessary. Doctors have no clue. They think that the disc space has to be restored, the bones have to be pulled apart. It is absolutely 100% not true. We are curing people's pain without doing that. We've been doing it for 20 years. This is not some made up nonsense that we're just doing. We fix these people and their discs are collapsed, 100% collapsed, and they have zero pain, zero leg symptoms, zero arm symptoms, and they're doing fantastic. They're living normal lives. Why? Because the whole notion that you have to refill the disc is bullshit. It was told to you by somebody. It's very popular out there on the internet, very popular among doctors. They basically tell you that so that you have to have a cage put in and screws put in or an artificial disc. They're trying to sell you on that idea of having that surgery done, so they make up nonsense like that. I used to tell patients the same thing because that's what was told to me. I believed it until I found out it wasn't true. It is a lie. You are living in the matrix. Get out of the matrix. Time to free your mind and learn the truth. Take the blue pill.
Yeah.
Take the blue pill.
Next question coming from Ahmed on YouTube,
Ahmed on YouTube.
asking, are you using chemonucleolysis for disc prolapse?
We do not use chemonucleolysis for disc prolapse. All right, chemonucleolysis, what Ahmed is referring to is something called papain that is a derivative of papaya. It's an enzyme. It was used very popularly back in the 80s by spine surgeons for disc prolapse. They would inject it in the disc and it would try to eat up some of the herniation. It would eat the disc too. And there were a lot of patients that developed what's called transverse myelitis, which is basically they became paralyzed after the use of chymopapine, and they were paralyzed. And so the FDA took away the approval, and it's no longer used in America. It may be used in other countries, but we do not use it. It's not a good option. We do a curative procedure. It's very easy, the Duke laser disc repair. You don't need to inject anything in the disc, you just need it repaired.
Next question coming from Professor on YouTube,
Hello, Professor.
asking, what does it look like in the case of a disc herniation in the thoracic section?
Yeah, Professor, I'm not sure what your question is really asking, but what does it look like in the case of a disc herniation in the thoracic? We can fix thoracic disc herniations with the laser surgery you just watched. We just do it on the thoracic spine. It is on our YouTube channel. If you go to our Duke Spine Institute YouTube channel and look under thoracic Duke laser disc repair, live streams, you can watch me repair probably 20 or 30 thoracic disc herniation. So we do it all the time. The success rate is 99% elimination of pain in the thoracic spine. That's axial dorsalgia and radicular symptoms, and it's permanent. We studied those patients for 1 year after surgery.
Question is coming from Ahmed once more on YouTube, asking, laser is destroying the tissue, burning cells. His danger can develop complication in the future. I don't know if that's a question.
Yeah, the laser is not destroying cells. The laser is removing something called pathological tissue. Pathological tissue is bad tissue in your body. You don't want that tissue there. You want to remove it. And whether you use a laser or you use metal instruments, the goal is the same. Laser is safer, it's more effective, it's better for the patient than in a non-laser type treatment. So, yeah, there's no long-term sequelae. We've not had any long-term problems. We've been doing it for 20 years here at Duke Spine. I have personally been doing it for 20 years. So there's been no downside.
Next, coming from Not So Boring once more on YouTube, asking, Sir, but what about the collapsing of the disc causing foraminal stenosis? Is fusion or disc both needed then? I am in much pain and numbness trying to make a good choice. Thank you for your kind words.
Yeah, sure. So great question. So if the disc collapses, does the foramen get narrow? Yes, it does. Absolutely. You are correct. But even with a collapsed disc, the foramen is still big enough to accommodate the nerve roots. So that is unnecessary to do anything about the disc collapse. What causes impingement of the nerve root is not collapsing of the disc and narrowing of the foramen. It comes from the herniation that is pinching the nerve in the foramen. That's what causes the nerve root symptoms, and that can be fixed with laser. That's what we fix with laser.
Next, coming from Denise, once more on YouTube, asking, how long can you live with a herniated disc on C5-C6 if it's pressing on your spine and causing pain but no significant neuro deficits? Is surgery a must, or can you wait it out for a few years?
So Denise, great question. I love your question. Denise's question is, Doctor, if I have a herniated disc at C5-6 in my neck and I'm having pain, how long can I wait? That's a question that only you can answer, Denise. How long should you wait? Knowing that we could have it fixed in 30 minutes here at Duke Spine Institute with that procedure you just watched, the Duke laser disc repair. Basically, zero complications in 20 years and immediate pain relief. Why would you want to wait? If you wait a few years, what are you gaining? Nothing. The disc herniation will not go away. Your symptoms will not go away. They only get worse. And you've just lost several years of your life, quality of life. So my advice, come to Duke Spine, get it fixed, and then have a normal life after.
Next, coming from Faisal, or on Facebook,
Hello, Faisal.
asking, Doctor, does a severely collapsed
Severely collapsed.
disc cause nerve compression on the nerve roots as they've disc height is removed and closes the space where the nerves sit?
So Faisal, your question is the same as the one I already answered earlier, which is fine. If you collapse your disc, it does not compress the nerves in the foramen. That is a misnomer, misinformation, a false belief. It is incorrect. What compresses the nerves in the foramen is the herniation. It is the jelly that was in the disc, now it's sticking out, hitting the nerve. The laser surgery we just performed is what removes that jelly. You do not need to restore disc height in order to get pressure off the nerves. That is a lie, misinformation. It's what surgeons tell patients, and they've told them for many years, but it's not correct. Thank you. All right, we have another surgery starting soon in about 10 minutes. How many more questions?
We have about 1, 2, 3, 4. We have about 4 questions.
All right, we'll try to get the next 4 questions done quickly, and then we have another cervical Duke laser disc repair. It's a patient with a herniation at C6-C7, single level, and we're going to have to wrap it up so we can get ready to broadcast. So that's great to have so many questions. We love the questions. Keep them coming. Go ahead.
Coming from MSM once more on YouTube, asking, under what condition could 3 discs be very thin or not exist at all and the patient not have pain or mechanical issues?
Yeah, so can a patient that has collapse of their disc, say 3 discs, have 0 symptoms? Absolutely. That's what I've been telling you this whole time. You don't need a disc to be pain-free. Most people with collapsed discs are pain-free. As a matter of fact, talk to anybody over the age of 50, and if they have 0 pain, 0 symptoms, get an MRI scan, and you will see a collapsed disc. Very common. Next.
Next, coming from Faisal once more on Facebook, asking, Doctor, why don't you treat tumors, either sinister or benign? Thank you.
Faisal, why don't I treat tumors? I can treat tumors. I'm a trained neurosurgeon. I've trained at the top neurosurgery training program in the world. So can I treat tumors? Absolutely, I can. I'm just so busy treating disc problems and facet problems that treating tumors is, they're very rare for the most part. Thank God they're rare. But also, a tumor treatment requires more than a good surgeon. You need a good surgeon, you need an oncologist, you need a radiation oncologist and a medical oncologist. You need an entire team. You need an entire therapy team. You need rehabilitation. You need a good neuroradiologist. So it requires a huge team that is very expensive to maintain that team, which I don't have the money to do that, and I don't have the volume of tumors to do that. Now, that's why you go to a tumor center where they do a lot of those tumors. They have everybody there, all the oncologists, all the therapists, everybody, and they treat those tumors. Yeah.
Coming from MSM, once more on YouTube, asking, do you provide a persuasive letter for insurance companies?
Yeah, so MSM, do we provide a persuasive letter to insurance companies? Yes, we do. For our patients with commercial insurances, we always do what's called a letter of medical necessity, and that's before the surgery, and we request that they consider the surgery for what's called medical necessity, try to get that approved. If they deny the surgery, we send it to our appeals team. Our appeals team sends in about 250 to 300 page document for the appeal. In that document, we have the FDA approval letters, we have peer-reviewed publications for the procedure, we have all kinds of documents and information. And if the insurance company still refuses to pay, then you have the option to sue them, and you have a nice administrative record to do so. We're getting ready, not us, not me, but we have about 50 or 60 patients that are getting ready to file a lawsuit against their insurance company for not paying, for denials basically. And we expect to win. Next.
And then coming from Denise, once more on YouTube, asking, is there a place to read or look up your 5-year follow-ups on your patients?
Yeah, the 5-year follow-up on our patient was peer-reviewed and published at a national meeting for neurosurgeons, so it would not be available to you.
3 more questions coming from Jerry. One from Jerry on YouTube asking, does severe spinal cord stenosis in the cervical cause a stroke?
Does a severe spinal stenosis in the cervical spine, can it cause a stroke? Yes, it can. It can cause a stroke of your spinal cord and leave you quadriplegic. That's why you want to treat it.
Coming from Faisal, once more on Facebook, asking, can you get mechanical pain after a disc replacement surgery without a herniation? What's the solution?
Yes, people with artificial discs, mechanical disc replacement, can get mechanical pain after surgery, and it's typically going to be in the facet joints behind the disc, FACET joints. That's the most common cause, or it could be adjacent segment disease. The best solution is to contact Duke Spine Institute, send your MRI in, and have me evaluate your pain and figure out why you're having pain.
And then lastly, not least, coming from Paul on YouTube, asking, have you had any success in getting the VA to pay for the surgery?
Have we had any success getting the VA to pay for laser surgery? No, we have not. I've even talked to senators. I've had VA patients come here and get the surgery that are very high ranking in the military and retired, and they have not been successful. The VA has dug its heels in. It does not want to pay for any new technology like this. It needs to change. We need to take the fight to the government and get them to change what they're doing. Somebody call Elon Musk. All right.
Is it for
Thank you
questions.
for joining us. Great questions. We got another surgery coming right up. Single level cervical Duke laser disc repair.